colleague, Dr. Carol Shields. First of all, I would like to thank her for accepting our invitation as always. And I would invite ma'am to please share her presentation and enlighten us with the wonderful topic of interferons in conjunctival tumors.
Thank you. Can you see my screen?
Perfect, perfect.
Okay, and I have no financial disclosures. And is it moving appropriately?
Yes.
Okay, so I'd like to speak to you on conjunctival squamous neoplasia, the impact of cigarette use and vaping, and where is the interferon? So let's review conjunctival tumors. We performed a large analysis on over 5,000 cases of conjunctival tumors, and we found that in our practice, 50% are benign and 50% are either pre-malignant or malignant. And what are the specific diagnoses? Well, you'll be sad to see that there are many different diagnoses in conjunctival tumors, from chorostomatous to benign and malignant epithelial tumors, and on and on. And here's the long list that we found in our analysis. But the big three are ocular surface squamous neoplasia, melanoma, and lymphoma. This represents about a third of the tumors that we see in our ocular oncology service. And there are several precursors like papilloma nevus, primary acquired melanosis, and lymphoid hyperplasia, another 1/3. But for the purposes of this talk, I will speak on ocular surface squamous neoplasia and will not speak on the melanocytic or the lymphoid tumors. So let's get on with ocular surface squamous neoplasia. This is a fleshy vascular mass, usually at the limbus, with leukoplakia. It's usually non-pigmented. It tends to occur in older Caucasian males, but it can occur in immunosuppressed patients, HIV organ transplant patients, and with smoking and now vaping. There are some factors to consider, like HIV and organ transplant, such as seen in this patient who had a heart transplant and squamous neoplasia at a young age. And squamous neoplasia can occur in small, intermediate, large, and giant sizes. Now, just this month in Ophthalmology Times was an article by Dr. Hall, which was presented at the American Academy of Ophthalmology 2021. They looked at the iris registry at the American Academy of Ophthalmology and found 15,000 patients with malignant ocular surface tumors over a 6-year period. These malignancies occur highest in the north central states in the United States and lowest in the West, and most prevalent in white males and smokers. We treat ocular surface squamous neoplasia either surgically or non-surgically. And here you can see an example of a tumor, but it's bigger than that. And it's even bigger than that. We always look carefully at the slit lamp for the exact size of the tumor. And when we resect it, we go wide, at least 2 millimeters around the tumor and with cryotherapy. So here you can see before and after surgery, a nice clean wound. And here's an example of the surgery with us applying absolute alcohol to the corneal epithelium, removing the corneal component with a 57 blade, cauterizing all feeder vessels, making our incision 2 millimeters outside the tumor. Often there's a lot of blood, carefully removing the tumor down to bare sclera, using a lumpectomy approach with a 57 blade, and then removing the tumor. Before and after, just 2 weeks later. Now, the diagnosis is not always correct. For example, this case came in with a gelatinous mass, but it had primary acquired melanosis, and that was an amelanotic melanoma, much more serious than OSSN. And this case, sent in as a melanoma, actually proved to be a pigmented squamous cell carcinoma. And this case in an African-American looked like a pigmented squamous cell carcinoma with some frothy surface epithelial abnormality, but we got an anterior segment OCT. And if you look carefully at that, you can see there were cysts within this mass, suggestive of a nevus, not a melanoma and not squamous cell carcinoma. And then this last case, frothy mass on the tarsal conjunctiva, referred as squamous neoplasia, but it was sebaceous carcinoma on biopsy, much more serious, and the entire posterior lamella of the upper lid had to be surgically removed. Now, what about non-surgical treatments? We have mitomycin C, 5-FU, interferon, injection of interferon, and PDT, all used for various different tumors. More and more nowadays, we love the use of interferon, but we're forced to use 5-FU. I'll explain that in a minute. Here we see before and after topical interferon. It works. It's an amazing medication for squamous neoplasia. And sometimes we inject the medication when there's extensive mass, and you can see the mass resolved, leaving only a small residua with interferon alone. Now, we reported in Cornea 2021 the impact of smoking on OSSN, and we found that smokers tend to have significantly more involvement of the inferior fornix and the inferior tarsus, and they tend to have larger tumors. So here you can see an example of a non-smoker with a tumor at the limbus, and then a smoker with a tumor in the inferior fornix. We ask all patients with OSSN about smoking and vaping. Here's a patient who was a smoker who had bilateral squamous neoplasia on the right and a little one on the left. Now, what about vaping? Well, we just published this in the Indian Journal of Ophthalmology a year or two ago. This was a young 17-year-old patient who had very fine epithelial thickening. You can see on intersegment OCT at the arrows. And sure enough, we resected it, and it proved to be intraepithelial squamous neoplasia in a heavy vapor who had 5 years vaped. You can see the dyskeratosis, the active mitosis, PAS with atypical mitosis, and active proliferation. So when do we use interferon and surgery? We use topical medications if the patient is medically unstable, but it requires them to purchase the drops, place the drops, and they have to be compliant. And these drops are expensive, except for 5-FU. We like to use surgery as our first technique because it establishes the diagnosis, and in 15 minutes, we have complete control of the tumor. The team out of Bascom Palmer have done a match comparative analysis and found that the cost was the same, whether the patient used interferon versus surgery, and the recurrence rate was the same, about 3 versus 5% risk for recurrence. Here's their analysis on cost comparison, and they found that it was equivalent cost for the full course of either topical interferon versus surgery. Now, there are rumors that interferon may not be available this year, so we have switched to 5-FU. Here you see a patient who had squamous neoplasia at the tip of a shunt for glaucoma, and after 5-FU, it all resolved. You can see on intersegment OCT the appearance, and then the tube shunt after resolution, and it has all resolved. Interferon has gone to COVID, and several major groups around the world is actively looking. We've even spoken to the FDA. They said, the American Academy of Ophthalmology said it is out of their control. And there is one company in China that is making interferon, but I'd like to speak to you about this later on. I will skip quickly, just mentioning that we occasionally do plaque radiotherapy when there is corneal invasion, and it does work, and we've published on this. So in summary, this is conjunctival tumors, ocular surface squamous neoplasia, the impact of cigarettes and vaping, and hopefully interferon will return. Thank you.